So here's the agenda. So we're just going to go over terms and definitions. There's a lot of expertise in this room, right? There's a lot of folks with behavioral health background, so it might be a bit of a repeat for you. I won't read every word on the slide. Then we're just going to talk a little bit about why trauma and resiliency informed care. So something that has been coming up more and more is really trying to not focus just on deficit, right? So not just trauma-informed care, but how do we also talk about resiliency? And what does that look like for individual people and for communities and for ourselves? Then we're going to talk a little bit about what are some applications in palliative care. Again, there's a ton of expertise in the room, so I kept it high level, and I would invite folks to sort of reflect on this and maybe think about ways that they have applied it themselves or have heard about people applying trauma-informed care. And then hopefully we have a little bit of time at the end just for some reflection. And I really think that in general, palliative care and hospice is one of the most trauma-informed disciplines that I've seen, right? I think that there's really a living out of this idea that when we're working with people in any stage of their life, we really need to be able to see beyond what's on the medical chart or maybe what the initial presentation is to see people as whole people and trying to meet people's needs with respect and sensitivity. And what we know is that what we might assume somebody's needs are might not actually be what their needs are. And trauma and resiliency informed care provides us some guideposts to be super curious with people about what that means for them and what that might look like for them. So again, really emphasizes understanding the whole individual and understanding the whole, right? So medical chart gives us amazing, important information. And also, it's important to know what is the environment in which that person is living? What does their work look like? What is their family system? If they're feeling comfortable sharing, what is their background? What is their experience in the medical system? Because we also know that the medical system can be trauma-inducing. And oftentimes by the time people are interfacing with you all, they have been through it. Many, maybe not everybody, but probably people have had lots of challenging experiences, either in the way that they've been treated, or maybe they've had misdiagnoses or a lot of confusion around their medical condition. And so people are coming to us kind of raw sometimes, right? Scared or super confident. We don't know. So again, this is the basis of really like trauma and resiliency informed care is to say not what is wrong with you, but what happened to you and how can I help? If I were to ask you to describe what is trauma, what might you say?
That experience that caused hardship in your heart.
Yeah.
Injury.
Absolutely. An experience that injured you, that heavy on your heart, adversely affect your ability to function. So a lot of times what people say is, I was one way before this happened, and then I was different after. Sometimes people say, what was different is that I had a lot of difficulty in A, B, C. Or they say I had a lot of difficulty for a little while, and then I was able to make meaning out of it. That's kind of the resiliency part of it, right? So that's the ability to bounce back, very basically. This is a little more clinical information about what trauma and resiliency is, but fundamentally, trauma is something that changes us and has adverse experiences for ourselves emotionally, mentally, spiritually, physically. And resilience is how do we make meaning out of that, incorporate it into our lives, and sort of, again, not have an adverse experience define who we are. And you can imagine, especially for people who have many traumatic events in their lives, that's super hard to do.
It's a question.
Yeah.
The word resiliency, is that something you can learn?
Yes. Yeah, it's a skill. It is a skill, and it takes practice.
Okay.
And I also, so there's, I don't have a lot about it in this presentation, But this idea of, right, so there's post-traumatic stress disorder, which not everybody who experiences trauma will develop PTSD, but there's also sort of I don't know if phenomenon is the right word, but there's also post-traumatic. And that's when we talk about the resiliency part. So post-traumatic growth is when you've sort of done the work, so to speak, done some healing, and are able to make meaning. Maybe you use your personal experience to then help others, sort of thinking about how does it inform the rest of my life. A lot of people find spirituality or maybe volunteer in their communities because they have the lived experience and they can sort of work with people and say, here's how I navigated this. So that's resiliency is a skill. It can definitely not be learned and practiced. And it looks different for every person.
I recently read something that said in childhood, the more resilient pieces that a child can build and we all experience trauma in our life. People have said even COVID was a trauma experience for some people. So the more childhood resiliency pieces that can be built into our lives, when we experience trauma, the more easily we're able to kind of ride that wave.
The more protective factors that people have in childhood, if they experience trauma, sets people up for very different outcomes, for sure. We'll talk a little bit about that in a second. So we talked about what trauma and resiliency is, and then when we kind of broaden that out into what is trauma-informed care, that essentially means that we apply the principles of understanding trauma and resiliency and apply it to organizations so that we know that staff and clients are experiencing trauma or have had some level of adverse experience, and that we are trying to fully integrate the knowledge into policies, procedures, practices, and settings. Super challenging, right? Very challenging, particularly if you're working in large health systems. And it is definitely a change process. And if you're curious to learn more about that, feel free to reach out to me. But the idea that an organization or a system that is trauma informed is the idea that everybody in that system has a baseline understanding of what trauma is and what it looks like to be working with the general population. And then there's 6 principles of TIC, which are defined by SAMHSA. So that's safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment, voice, and choice, and then cultural responsiveness. And then why? I mean, we kind of talked about this a little bit, right? It is just to have an increased understanding of the pervasiveness of trauma and how it affects both individuals and systems. And when I say individuals and systems, I don't just mean clients and patients, I mean us too. We are part of these systems. We are part of the estimated 36 to 81% of people who've experienced trauma. I think it's much higher. So that's why, right? Like, we are living in a world that is very challenging. We're working in systems that are extremely challenging and trying to help affected people navigate systems that are very challenging, while we are also challenged. Basically, this shifts the approach, not just, or from the individual, shifts the focus to the individual and conveys that their life is understandable, and maybe most importantly, that their behaviors make sense when understood of a whole picture, which I think is really, really crucial, because all day long, we are observing people's behaviors. And when we are not curious about people's behaviors, we are judging them all the time, in the grocery store, in traffic, to our coworkers, to our family, right? So having a trauma-informed lens sort of shifts that a little bit and allows us, hopefully, to become curious. So I did a training. I've been doing these trauma-informed trainings with residential behavioral health workers at Opportunity Alliance in Portland. So they're mostly staff of group homes. It's great because some people have been there for 4 days and some people have been there for 30 years. And I had somebody ask me yesterday, we've been doing exercises about like, how can you apply the principles to your daily work? And somebody was like, there is this client that we have who every single day comes and asks 4 hours before they're supposed to get their meds to take their med. And I was like, She was like, I just don't get it. The doctor said this is the med window. This is the med window. And every single day she's arguing with us about when to take the meds. And I said, why do you think that is? Why might that be? What are some ideas? What do you guys think? Well, somebody said, maybe once or twice or half a dozen times, somebody provided her medication late and she had adverse experiences from that. There were bad outcomes because her medication wasn't delivered on time. Why else?
She got in trouble for not showing up when she was supposed to show up.
Yep. Maybe her entire life, she's had people telling her exactly what to do and when to do it. And it's her last ability to exercise control. Right? So on the surface, we're like, this behavior is so annoying. For this person, I think, was basically saying, this behavior is really frustrating. And so it was an opportunity to just say, like, let's become super curious about what that behavior is and what is the need that this person is actually trying to do. It doesn't mean we have to agree with the behavior or what the need is, but it is true for them. So you all know this. Why does trauma-informed care matter in palliative care? So we know that people are in pain, scared, they have unresolved grief, they have anticipatory grief. What else might come up? What have you all seen that comes up?
I've seen anger, a lot of anger.
Yep, totally. Have you guys seen the feelings wheel? My social worker was smiling at me. Everything on that feelings wheel is probably going to exist, and many of it is probably going to exist simultaneously.
Yeah.
Many things can be true at the same time.
I think that's what they forget. The obligation to take care of my mother, but I'm adopted and she lied to me, so I'm blah, 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 blah.
And that is not an unusual example, right?
Right. We had a family conventional relationship between the daughter and the father, and a conventional relationship between the mother and the father. It's a lot of conflict. It's a heavy load.
In so many ways, right? So let's just name all the ways that is complicated. How about for us? What comes up for us when we hear that story?
I'm not understanding. Confusion.
It may,
Unrelatable.
I think that it probably hits on what we consider our own morality. Maybe we have not just judgment, but disgust. Yes, and we're humans.
Yeah.
Right?
Yeah.
And so it's okay to have judgment, but what is the next question we ask ourselves? What information do I need that will allow me to be present with this person? Or what information do I have to let go of to be present with the person? Because I say all the time, I thought I had heard everything, and then I hear that I meet someone else. And then I hear something new, right? Like, I haven't run into that one yet. There's time.
Okay.
There's time for something similar, right? But I think your initial example of sort of like, I ran into this a lot with the population that I worked with, especially when people were sort of nearing end of life and have long histories of substance use disorder, right? So I'm thinking of one woman I knew who I had a very lovely experience with, but I met her when she was 60 and unwell. And she didn't owe anything to me. I was her case manager. And I was there sort of with positive regard and just there to be a helpful tool for her in navigating the system. But that was not the experience her children had with her at all. And it was very interesting for me as she was entering hospice at Gosnell. Her son, who she'd been not in touch with for many, many years, basically saying to me, like, I don't want to be here. I'm here because it's the right thing to do, and I want to show my kid that this is what we do,
That's great.
right? And so, like, when we talk about the family system, so there's the individual, right? So this woman, what trauma might be coming up for her in this example? Guilt, shame, regret, sadness, anger. Why can't these kids just let it go? Love, affection, comfort that they're there. And it's all happening at the same time. And we're walking right into the middle of it. Right? And it can be so difficult to figure out, who do I attune myself to in this situation? Or how do I shift my attunement depending on who I'm talking to? This is super hard work and complex work because we are complex. And then what if you add into it, I'm the adult child of a person with alcohol use disorder or alcohol. How might that affect my ability to use a trauma-informed lens in that setting? Because again, that is not a unique experience either, to be the adult child of an alcoholic. And listen, there's nothing wrong with entering into a field where you use lived experience to help other families. How many doctors are doctors because their family members are doctors? Right? I think sometimes there's some stigma, even for us, for social workers, around who we choose to work with, depending on the population you're in. But yeah, this is basically what we just talked about. So how does a trauma-informed approach as providers address some of the examples that we just talked about?
So like if the nurse on the team wants you to be focused on one, because this is what we need for things to happen, you know, like you're walking into that trauma situation for the family, right? Like there's a lot of different moving parts. Things that are a little bit more complicated as your role on the team.
For sure. And I'm glad we have some nursing students in the room.
I don't mean any negative.
No. This is the opposite, really. It's actually about how care teams do you align, right? Because like I have worked with trauma-informed nurses who it's like, if we're on the same page and my role is clear and their role is clear, but the way that we talk to people and what we consider is in alignment, that is beautiful. And when it's not quite that way, it can be really uncomfortable. And I'll also just say, clients, patients, they can tell. They know. They can tell when we're not speaking the same language as other team members, especially for people who have experienced a lot of trauma, because there's already a danger orientation. So what do I mean when I say a danger orientation, and why might that example spark fear? Yeah, high alert button. So I also think for patients who've been in medical settings a lot, who maybe are doing a lot of the hurry up and wait, like it's very entertaining to observe what's going on in a medical environment. I remember my mom was chronically ill. I remember like sitting with her and observing everything. Because you're sitting around a lot, you're waiting, right? And I remember being like, I don't think that makes sense. Right? As a social worker, I was like, I want to figure out who's friends and who's not friends. But that was what, like, that's sort of, you know, I was the kid who was eavesdropping in the restaurants. But some other people might be like, I want to see how they get along, because if they don't, that means I'm not going to get good care. Because 6 years ago when I was in the hospital, the doctor and the nurse got in an argument with me, and then there was a med error. Right? So what can be really hard for us as providers and as care teams is that sometimes we are wearing the mistakes of people who came before us, And sometimes we'll make mistakes ourselves. And so using a trauma-informed lens is also exercising that trust and transparency ourselves to be like, I'm really sorry. I wish I had said that differently. Or I realized I was going so quickly through what I just shared with you that I didn't get a chance to ask you how it landed. Just things like that. Like, that is a trauma-informed response. It doesn't mean that every time that you interact with somebody, it's going to be perfect, because we're humans. And what people don't see is that our invisible backpack is full of our own family health problems, personal health problems, trying to get our kids to school, trying to get our kids into college, trying to get to work on time, a supervisor who told us that all of our notes are late, insurance companies calling us, yada, yada, yada. So we are also behaving because of things that are going on. We don't have to be perfect, we just have to be self-aware. Yeah,
And generational trauma.
totally.
If you have a strong family history that tells stories through the generations, and you know certain issues or conflicts that you come from, your family comes from a country where there was war, a lot of conflicts, so stories come down to you, right? And they're part of you, they're part of your existence, they're part of the fiber of your being. So
Yeah,
not only from your birth now, but also stories that made you.
stories that made you, and maybe sometimes stories that you don't know anything about. So my husband is from Rwanda, and his mom died when he was 5, and he doesn't know how she died. And she has living siblings. Nobody talks about it. Right? So I've been kind of like, I wonder if they talked to me about it. But we'll see. But it's that kind of thing, right? And also in his community, right? He was 12 during the 1994 genocide. Many of his friends lost parents in the genocide. What does that look like? Our wedding, there were no elders on his side. What does that look like as our generation ages? His friend, they don't have medical information about their families, right? So, and I think it's also interesting to think about, our friends' kids, our kids of genocide survivors. What will that mean for them, the first generation born in the US? And to your point, we think about how is trauma reflected in populations of people and institutionally and community-wide. So there's a long-standing stereotype of the neurotic Jewish mother. Jewish women neurotic, or are they? But how do we look beyond the behavior? What might be the reasons for behavior?
They resented it.
If your grandmother or mother survived the Holocaust and you have a persistent orientation to danger, that's going to look a certain way. Do Indigenous Americans have an alcoholism gene? Or did they develop coping mechanisms for hundreds of years of trauma and genocide? That's kind of the interpretation, right? So when families carry the trauma, it does impact their ability to support the patient. And communication gets weird or goes away, or people who maybe haven't been involved in care their family member's entire life, all of a sudden are right in it and know best. I'm sure we can think of 1,000 examples. Families are hard. And also I'll say, I think that palliative care and hospice can do wonders with families to give them permission to feel how they feel. Because sometimes the other family members can't do that, but sometimes even in a small moment can say to somebody like, it makes a lot of sense that that's what's coming up for you. Yeah.
I just recently been more and more challenged and honored in my practice. I'm in the Mid-Coast area where we have a high veteran population, and we're seeing more and more Vietnam vets, which is a very complex population. And part of what I'm seeing in my work with families is they're mostly guys that came back and never spoke truth to their experience, never shared it, saw atrocities, we got atrocities, that the family has nothing about, but here they are now getting towards their end of life, doing life review, trying to put their meaning, put it in order, confess, if you will, to speak. And it is, I need more education. I've been a social worker a long time. I do what I can. It's very challenging. And it's also probably some of you have had that same other experience where, so you doing the work and doing the life review and creating the trust and the rapport and the reciprocity. And then they begin to share and, being, and I can hold space. I'm brave. I can be there. I can hold the space. But how much you're opening up something that is that fair to them to do the more exploratory question. Anyway, I just share that. It's a really, and we're going to see more and more of that population in our care.
I think it's a really interesting ethical question. I think it's so interesting, right? Because it's like, how do we build a container around that so that it's not distressing when really we're there to find ways to create peace? And it's like, yeah,
Or these are
that?
the barrier, like what we have a lot is same human that will not access VA benefits, will not. And so you are witness to the struggle of loneliness and being destitute and having nothing to support them because they will not allow the VA to help, because what the VA can offer, we all know. And will
And we
not.
know why.
Will.
And we know why.
Yes, we do.
They
And
don't
we
want what
we
they
honor that, right? And as a human in their space, you honor, you absolutely, we're going to stand by you. We're going to find a different way. But there are no other ways.
It's so hard.
There's nothing.
Right, and I think,
It's like double jeopardy loneliness, to your point too, but some of those folks are disenfranchised who don't want to access VA services.
Yeah.
Nor do they want their family to know. I mean, because that is their nobleness that protect them. But the family here is like, well, he's been, and so I'm trying to do some reconciliation, right?
oh, yeah.
Yeah, but honoring his truths and his secrets, it can be incredibly complex. And sometimes I've asked permission, you have told me holy things. Can I share part of this with your family so they can better understand what, and seek some forgiveness
And
prior?
And we've noticed that in Washington County is that they may give permission after death. And give you permission after death, but while I'm alive, that will not come after.
Yeah, so sometimes they've
So
written
that-
letters and
That's an
they dictate and I write the letter
twist on
to
it.
give to them after death.
And it's so hard, right? Because what did we then hear from the family member? I wish I had known.
Yeah.
Right.
Yeah.
Of
Why
course
didn't
they
he feel
are
like
that.
why didn't they feel like they could tell?
Exactly.
And so then we have this next
The next
stage.
legacy. Yeah.
The next legacy, the
Yeah.
next, maybe that conversation then looks like this may be an opportunity for you to get some support around this, and your loved one wasn't able to do that for whatever reason, and maybe this is an opportunity.
And it's the same with sexual abuse and that comes up particularly
Yes.
with female population, right?
Oh,
Not
huge.
like it's just, so I know you guys, we do hard work. It's
It's-
like,
I'm having chills throughout, I'm really having chills throughout the entire conversation.
Yeah.
Because it is so complicated and we're only just talking about the patient side of it. We're not even acknowledging all of the complexities that surround this.
Yeah, I
We're
think,
talking interpersonal.
Like, it's interesting, and we had a social work going forward there, had a question for me regarding how was I supporting ladies here? How do you support your staff,
Yeah.
manager.
Yeah.
How do you support your staff through it? And I don't know. And I am trying really hard with being a nurse and not a social worker, not spiritual advisor, but you as a manager want to hold all of your staff together and say, yep, you had 70,000 deaths this year and they all sucked. And some of them didn't go the way you wanted it to, and they were pain, it was bad.
Yeah.
And then some that were beautiful, and thank you for doing that, and thank you for being so smart. And there are some children, and the child death, and anyway, how do I support what do they call that?
What did we do with it? The vicarious trauma.
Yes,
And the secondary.
death,
stroke.
and death,
Yeah.
and death, and death, and death, and death.
And we could have a whole day where that was the
How do
topic.
you do that?
I think that we should. I mean, really, like,
Let's do that.
even for people, like, I recently did like a staff resilience and self-care.
Love that.
thing.
Yes, I need that.
I know, we do too. And it was really interesting for people. There's actually a questionnaire that you can take called the ProQual. It's PROCOL. It's available online. It's a professional quality of life questionnaire. And it actually assesses your level of burnout, secondary stress, and vicarious trauma. And it was really interesting when people took it because they were like, my burnout is low, my vicarious trauma is low, but my secondary stress is high. And I don't have the definitions in front of me, but the one that was high was that because of hearing other people's life experiences, it changes the way you see the world.
Yeah.
People were like, I'm surprised it's so high. But I was like, do you know how many social workers I know who don't let their kids go out and sleep over?
Yeah, right.
Who don't have a history of sexual abuse in their own families, but because of all of the families that they've met, do not let their kids go on sleepovers? That's what that is. We've seen and heard too much. How can it not affect the way that you see the world? It's not possible. And so I think it's a little bit about framing and not to oversimplify it. But like when I was doing case management with chronically homeless people, I would be like, what am I even doing? I have nothing to offer them. There's no housing. This was before Medicaid expansion. I heard about that, but this was before Medicaid expansion. So I was working with a lot of able-bodied adults without dependents. So they were not qualified for anything. Many of them who prior to the LePage administration had been on opioid maintenance programs and doing very well, lost Maine care, went back to using on the street, ineligible for everything. I just remember being like, what am I even doing? And having people I supervise come to me and being like, every day I leave and I feel like I've accomplished something.
Right.
And so, right, it's like, yes, and that's so untrue because you are there present with a person and that the sacredness of that relationship. And so I think about like the veterans who are by themselves by what seems like choice, but we're there, you're there. And maybe you're the only person that's there. And that burden is real and it can feel so heavy. And what a gift. What a gift to that person and to us. What a privilege to sit with people when they don't feel like they can let anybody else do it or everybody else has felt like they can.
Oh, I think it's all right.
I know, I didn't.
No, but this is part of it. You know, I really, last night, we're at the 5th year mark of COVID, right? And I was practicing all through COVID and my year and holding the iPad, saw many people die. And I realized, we've never processed this.
No.
And I said to my husband, I'm having some PTSD right now, just the news.
Yeah.
Yeah, so hopefully we can do some work around that too, because That was unattended to. We were
100%.
gone.
Yes,
You had to.
Yeah, we had to, right? So,
unattended to is, and really like that is the thing too, right? It's like, you probably did have some post-traumatic syndrome.
how could you not? What
How could
people
you not?
wanted to do. You know, it's not, and then you hear people like they're missing that pandemic because they got to stay home and not work. You know, there's this disconnect, and I'm glad for them. And I realized, what? You know, that was so not my experience.
Yes,
It's, you know, probably someone that's in this room too. You had to show up every day. You had to gear up. Yeah, and felt safer in the hospital than in the community.
For people, I think it's the news. People are talking about the vicarious trauma from COVID more now than I've heard in the past years. So I do think there's some sort of funny connection with everything going on in the news.
Mhm.
People are watching it in a different way, and it's affecting people in a different way. And COVID is coming up more. It's been a funny couple months about that.
Interesting.
Yeah.
yeah.
About the healthcare system, how functional it is, and communicable disease, and all of those topics are in the news all the time.
I think it's really true, right? And I think that it's worth acknowledging for us too, that around all of the different healthcare things in the news and cuts to things. So permission to go back to the slide. Just to transition a little bit, because what I am hearing loud and clear and feeling is that there's a lot of work to be done for us. And so that might be some feedback I give to the organizers of the conference, that there might be some sessions either like before next year.
Yeah.
Let's do some stuff before next year to attend to us. Okay, yeah. Thank you. And I'm glad we have a little bit of space for it today. So real quick, here's some variables impacting trauma severity. We talked a little bit about that before. So the type of event and the intensity of exposure. So the example that I give a lot is there are two people in car accidents. One person stops short and goes off 295. They're okay. They have to get towed, but they're going to be okay, even though they're super stressed. Another car accident is a 7-year-old passenger in a truck while their dad's driving in the Great North Woods. There's a snowstorm. It's 4 a.m. They're going hunting and they hit a moose. So those are two car accidents with different intensity of exposure. Frequency, one time or ongoing. What if the person who slides off the road on 295 is the 7-year-old as an adult?
Mhm.
Then what does that look like for their response? So they've been in another car accident. Maybe their trauma response is much higher. Maybe they're actively having a panic attack because of this, because it's activating what they've experienced. How does it happen? Who witnessed it and who learned about it? So in the instance that the person slides off 295, tow truck comes, Sadie says, "Are you okay?" You say, "Yep." In the truck incidents in Ruth State County, in the county, your dad's intoxicated. That's why he hit the moose. The state trooper comes up and is pissed, is yelling at your dad, "You're 7. You're thinking, "Oh no, I've been asking my dad to go hunting for 3 weeks. This is the first time he's been able to go and been off work." Then you go home and you're upset. And maybe your mom also says, "Why did you have to ask him to go hunting for?" Right? So who knows about it? How did they learn about it? When did it happen? Quality of the response. Or you go home and your mom wraps you up in her arms and says, "That must have been so scary. Dad's been having a really hard time. We're going to make sure that he gets some help." That's a different quality of response. Was dissociation present? We work with a lot of people who say, "I don't remember anything about my childhood." All the time. I don't know. I just don't remember anything about my childhood. So did that person, the 7-year-old, block it out? "I know I was in a car accident, but I think I was 5 or maybe 9. I think I was on my way to my grandmother's house. right? So there are parts of that that have been kind of dissociated from. And then access to support and resources. So again, what kind of family culture does the 7-year-old have? Are there resources at school? If they're ill, something nearby? All of this stuff can matter. Because we might meet the 7-year-old when they're 60, and they might still have an old injury from when they broke their leg when they were 7, and nobody took them to the doctor. Those are the variables impacting trauma. That's a quote unquote benign example of a car accident. But I think we can think of war, think of abuse, and sort of imagine what that looks like over time too. So you know this, signs of distress, emotional, physical, behavioral, and cognitive. Is there anything missing? Definitely. So sometimes we see these signs or symptoms and we don't know where they come from. So sometimes when you're seeing some of this stuff come up and you're like, I don't understand where it's coming from, again, it's an opportunity to become curious.
I recently had a client introduce himself to me and said, the first thing you need to know about me is that I'm an asshole.
I love it.
And I was like, great,
What a gift.
that's a place to start.
Yeah.
Good.
Thank you.
We'll work with that. I'm an asshole. Okay, great.
Yeah,
Yeah, let's talk about
I love it. What will that look like with me?
Right.
How will I know when he shows up? Yeah. Yeah, and it's like, who said that? Who told you that? I have a real soft spot for the grumpy old men, especially those ones who are
Yep.
like, I had this one client who I just adored, who was a Vietnam vet and had really significant heart problems, super stubborn, just wouldn't, and really acted like he barely tolerated me. And I was like, he's my favorite.
Mhm.
Every time I came in, he'd go, hey, trouble. And I said, yes, got it.
Yeah.
So, I mean, again, this is not new for you all, right? Trying to be gentle and non-invasive, asking permission. I think even the example of a life review to ask permission, I think this might be helpful for people to know. What is your comfort level with you sharing this? Obviously, we would never do that without permission, but I also think even that asking opens up a new area to discover. If you are a medical provider, right, explaining procedures clearly and offering choice when possible, and creating a calming environment, I would say that's important for all parts of healthcare. Often it can feel so institutionalized and harsh. And so I think about even clients or patients that we've had who have histories of psychiatric hospitalizations or incarceration, and how sometimes the environments that people are in can mimic trauma-inducing settings that they've been in. So if you're working with people who are currently incarcerated or formerly incarcerated, that can be really important. The piece around choice and the piece around a calming environment. We talked about this with families, acknowledging the trauma histories, sort of encourage storytelling and meaningful rituals. Of course, if there's a lot of stuff, that can be hard. But sometimes questions like, was there ever a time when things didn't feel so? Was there ever a time in your life where you felt like you were connected here? What did that look like? And providing resources. That's pretty all in your wheelhouse.
Ask him. Never been alone.
Yeah.
Especially when these isolated people.
Yeah.
I was just thinking, yesterday I had to move somebody. We have life flight at the hospital, and I had a veteran there, and I finally figured out we moved this room because he was right near the pad. And every time the chopper came, so. But it took a while, he didn't want to say anything because.
And but that's a good example of stuff comes up.
And
I was in one of my other trainings, somebody said we were washing the floor with Pine Sol and somebody had a huge reaction. And it was because they'd been assaulted wow, there's that smell, right? And so being trauma informed means we do everything we can and we will still be surprised.
Yeah.
And it's how you attend to it,
Yeah,
right? Like it's how you attend to
and
the,
see the person ask every time, well, I had, what's going on?
yeah.
And so, well, I just need to. Yeah. And then we had another long-term patient where I got them a beautiful room off the front of the hospital, could see the woods, but it was also a place where the hearse came. To
Uh-huh.
get, know what to do, right?
Yeah.
Like,
Right.
okay.
Yeah, I mean,
Yeah.
listen, we
It
do
just-
what
and
we
they
can do.
And it was, I'm gonna present this case this afternoon, an ALS patient. She's
Mhm.
watching and she couldn't leave the hospital, she's watching the hearse every day.
Mhm.
Like, I saw the horse, she saw the hearse. Right, okay, so, yeah,
Voila.
yeah.
So within care teams, student intent, you guys do debriefs
Try to.
Sometimes, yeah,
if it's very
I'm sure.
complex.
Yeah.
We gotta talk about it. And because it's like, this is the stuff that like, you're not gonna go home and talk about all of this stuff with your family. Not only can you can't, but also like,
You want to bring that home.
have you been in situations where you're with a friend and then your partner's there and you're talking to your friend who does the same work as you and you're talking about work and they look at you like,
I don't ever want you to be my nurse because you are so, yeah.
or they're like, that happened, that you saw that happen. So benefits, right? We know this, reduces emotional distress, enhances feelings of control, allows for the complexity. I think that's maybe the most important thing is that it just lets people be complicated and allowed. Hopefully, we're supporting the communication and understanding, again, allowing for the complexity. Well, you don't have to fix things, I think also is the important thing. It's like, we're not there to fix decades worth of dysfunction. It's not possible. So we are visitors into this moment of time. We're invited in, we are guests, and we do what we can, and then we try to live our lives the best we can. Being trauma informed within your care team, it really does improve team morale and reduces burnout. Because it's kind of that thing of like, it's acceptance. Do you want to fight against everything all the time? Or do we just want to allow people to be people?
I have a question about that.
Yeah,
So with the care team,
yeah.
at what point does it become, and I don't know all the words, but trauma bonding, where you
Like
create
day
day 4?
I'm joking.
Wow, I'm
really
like, holy shit. Like,
Well, I
we're
mean,
all
trauma
bonded.
bonding, I
Like-
mean,
We are all, and so we are all just,
so I think it happens very quickly.
it does, it feels quick.
It happens very quickly, trauma bonding. And I think you don't have to live there in relationship. I think that if you're intentional with it by saying like, what are the spaces in which we are going to
Okay.
debrief
Okay.
challenging events, you
Yep.
gotta create some containers.
Yeah.
What I recommend, and I wish somebody had told me this when I was 25, was don't go out and drink with all your coworkers after work.
Good.
Which I didn't.
Okay.
So unhealthy for us as 20-somethings in an environment where we were experiencing trauma and had no tools or resources to deal with it. And then the trauma bonding was happening not just at work, but in our personal lives too. And so that's why I say like, it's gonna happen. It's what we as humans do. It's why you even hear people use military terms for the work that we do. It's why you hear people say, oh, you're in the trenches.
Mhm.
You're on the front line. Like those are military terms. And what do we know about people who like people bond together because there's danger and risk and personal safety and other people's safety. So that's what we as humans do, is connect and bond around shared experience. And I think a lot of it is that like, this is not the only experience of our lives. And so if all we're doing is bonding with people about all of the horrible shit that we see, that's all we're gonna see. And so really like, and this is kind of like the self-care piece, of like, there's stuff the organization has to do, your program has to do, but then there's the personal responsibility piece of it, which I think it's easier as you age in your career, as it did for me. And you're able to kind of like make some different choices. I think early in my career, I felt very proud of the fact that I was working with the hardest. And I learned a lot. And I'm also enjoying being able to work with people now who leave sessions and have a place to live and not worry about people dying outside. Right? But my 25-year-old self might have judged me for that. I was traumatized. So we know the challenges. Time constraints, other people aren't trained, emotional toll. Some solutions, training and education, prioritize staff well-being and support. This is for management. This is for leadership, just to be clear. Right? Like this is for leadership to get creative around. And a lot of times what's missing is that there's not trauma-informed training from the top down. I just want to say that out loud. Okay. It's 10:54. Any reflections in our final moments together?
Great information. This was wonderful.
Yeah, I mean, what a gift to me to be able to learn from you all.
I think the takeaway, Hillary, is that we do need to, and have this moment, for me, I'll just let myself have this moment of pause and think about my practice and need of other kindred souls. And we still have a lot of work to do. And as social workers, you know, I think about patients and families, but I also think about my young nurses, you know, I call my, I just think of, as I got a little mentoring and Dave Branch, I was leaving the hospital and I was saying goodbye to one of the nurses, I just asked them how they were, and them just started to cry and said, "Can I have a hug?" And I said, "What's going on?" And them as trans and scared out of their mind. And we have a lot of diversity in our hospital, which I'm very, very proud of. But damn, how are we going to, like, I'm not trying to give you another job, but how are we going to attend to
I know.
those helpers who,
It's the next phase of my career because I remember that 25-year-old self. And I was lucky to have mentors like you who were like, "What's up, honey?"
you could just,
You know,
right?
But I think it's the question, and maybe more important than ever, as we head into whatever the next, of our culture is going to be. Sort of super high level.
And how do we make? And all I can say to them was, I have you, but I don't know if I do. I'm okay.
I know. But, and you do.
Yeah.
And you do have
Yeah,
them.
but it's just, you know, it is a whole team of, I know we're all strong and broken places, but these are hard times and it's worrisome. Like forward.
Very.
But thank you for doing the work you do. This is great. I never heard of someone who was the chief of culture. Like I found my person. I don't know what chief of culture to do. Thank you.
Thank you
Thanks,
so
Lori.
much.